Good morning, everybody. Today we are going live, and this time our presentation is on the device. One of the important topic in the pacemaker, and particularly it is very commonly asked in the IBHRE. The most difficult question in IBHRE is more related to the pacemaker than CRT and ICDs. And it becomes more important when we are having a lengthy question and a very simple solution if we are going to see the particular EGMs. Crosstalk is one of the important topic which is again time and again asked in the IBHRE questionnaires, and very simple to identify. But yes, the mechanism how to identify and what are the ways to treat it, or we can say in what scenario it is commonly developed in a patient of pacemaker, what type of pacemaker it will be, how to identify. So with us today, Mr. Kishan is there. He's IBHRE certified certified specialist from ABBOTT company, and he will be giving the presentation on crosstalk. So over to Kishan. Kishan, you can come. Why it is not coming? Go ahead.
Yes, sir. Starting from the point of PMT, sir. That's what. So, good morning, everyone. So, as Dr. Ashutosh has told to present this pacemaker-mediated tachycardia. So, we are talking about the pacemaker-mediated tachycardia. I named it pacemaker-mediated tachycardia. Pacemaker initiate the tachycardia in certain situations. What are those situations we will see? So most commonly, this is the rhythm in certain situation. This is the initiated by the pacemaker tachycardia. So we can see this all of a sudden ascens V-pace is happening after one ectopic. So it has initiated the tachycardia by the pacemaker. So how does it happen, and all we will discuss deeply on this. So this pacemaker tachycardia will happen in the two scenarios, in the dual chamber DDD mode and VDD mode, not in the single chamber, because basically pacemaker mediated tachycardia happens because of the retrograde P wave which is sensed by the atrial lead. So that is what it will start the pacemaker mediated tachycardia. So what are those situations? We will see. How does it initiate that one? So this is the, in DDD or VDD pacemaker, the initiation will happen because of the retrograde conduction. So the ventricular, after ventricular contraction, it goes back to the atrial through the AV node. When AV node is out of the refractory period, the contraction goes back to the atrial, that is sensing by the atrial lead, and it will start tracking into the ventricular. So that is where PMT will start, pacemaker mediated tachycardia. So this pacemaker-mediated tachycardia, most of the times it will happen at the maximum tracking rate. Or very few situations it can happen also smaller than the maximum tracking rate interval also. So how and all we will see in further. Yeah, most common initiation PMTs because of PVC is the most common cause. When there is a PVC occurs, definitely retrograde conduction will happen. So which is sensed by the atrial lead, and it will start tracking into at rapid rate of the MTR. So first the cause is the PVC. most common thing. And also there are other scenarios. Atrial loss of capture also one scenario. Due to this also it will initiate the pacemaker mediated tachycardia, and also atrial undersensing also will cause, and PACs also cause. And when you are keeping the magnet over the pacemaker and while you are trying to take out the all of the sudden, so this is also one of the cause for the PMT. So these are the
Magnet removal means magnet is always going to
yes
disrupt this one.
yes sir, when you are keeping the for surgery more something, so you are taken out the dual chamber pacemaker, you are taken out that one. So if when you while you are keeping the magnet over the pacemaker, it will keep on pacing at the synchronous DOO on certain rate. So while you are taken out, so it may pace competitive pacing. So before that you are pacing at 80 or 90. So all of a sudden you are taken out. So it may come back to the synchronous mode. So that may disturb that synchronous AV synchrony. So that can be also reinitiate the tracking, sir. PMT. And also one more, atrial oversensing also can cause. Here it is not mentioned. These are all situations, but most common thing is the PVC. That is the top priority. Because of PVC, most of the times we see in our pacemaker interrogation also, because of PVC, it can initiate the pacemaker mediated tachycardia. So how it happens with PVC? So simple, like when extra beat is occurring, so after contraction immediately extra beat is occurring, so that will go through the AV node to the atrial. So because while it is PVC is happening, AV node would be the out of the refractory. So that is where it will reach to the atrial. So atrial it will sense and it will start tracking into the ventricular. So that is where initiation PMT will happen due to the retrograde PVS. In all these scenarios, so all of these scenarios, so it will be the retrograde PVS sense will happen. So it will start the initiation of the PMT. So this is what we can see here. Yeah, one PVC is initiating the retrograde P wave. So it start sensing that retrograde P wave in the atrial lead. So that is where it is started the PMT with one PVC. So, and one more scenario, loss of atrial capture also, it will reinitiate of the, because when there is a loss of capture, in intrinsic rhythm of intrinsic P wave will come and fall in the out of the refractory period. So it will start sensing of the atrial and will start tracking in the ventricular. This is also one cause for the PMT initiation. So this is where we can see in this ECG. So A pace, V pace is happening. So at some point it is loss of capture is happening. So then after that it is continuing of the loss of capture. At one point this intrinsic P wave is falling out of the refractory period. Then I started the initiation of the pacemaker mediated tachycardia. Yeah, all those scenarios, retrograde P wave is the causes. So how to stop this PMT? We can see what kind of therapies we have available in the pacemakers. So we can see. So if we do not have any programmer, so immediately if you have the magnet with you in your device clinic and hospital, so you can place the magnet over the pacemaker to stop immediately from the PMT. But make sure if it is ICD and CRTD, so therapies will disable for the movement as long as you keep the over the device. So that's you should make sure to have the backup for that, and it will go back to the Vivo mode for temporary base as long as that magnet apply. So but when you are applying the magnet, it will terminate the PMT. Yeah, this is another situation. Loss of atrial sensing also can cause for the initiation of the PMT, because when there is a loss of atrial sensing, it will overpace in the atrium. So that overpace again, it will cause to the loss of capture, and loss of capture again reinitiation of the PMT. In similar last slide we have seen that due to the atrial loss of capture it is initiating. Here also it will, this atrial loss of sensing will lead to the overpacing in the atrial, and this will lead to the atrial loss of capture, and similarly it will initiation of the PMT. That's what we can see here. Loss of one atrial loss of sensing is happening, then it is pacing, overpacing in the atrial, competitive pacing we can say. When competitive pacing is happening, it will again loss of capture in the atrial. This will reinitiate of the PMT. Yeah, here it is mentioned about the same thing, retrograde conduction, how does it happen, and also basically the conductions when after ventricular contraction, if there is extra bit comes, so that AV node will be out of the refractory period, then it will reach back to the atrial. That is what retrograde conduction happen. Yeah, in pacemaker we have how to prevent. There are the two treatments. One is the prevention of the PMT. One is the treatment of the PMT. Prevention is better than cure always, as we all know. So prevention is pacemaker try to prevent before it occur. So how does it pacemaker does prevention and treatment? We will see. The prevention of PMT, when there is a PVC is occurring, so it extend the PVAR of certain period. So in Senjure pacemaker, in ABBOTT pacemaker, it extends to the 480 milliseconds. So we can see here. Yeah, this is where. So one PVC is occurred on one PVC, it extends the PVAR to the 480 milliseconds, so that your retrograde PVAR falls in the refractory period, so that it will not initiate it will make sure to not initiate any kind of PMT. This is the prevention of PMT. So PVAR will extend on the PVC. That's what we can see here. One PVC is extended the 480 milliseconds. Yeah, here you can see on one PVC it extends the PVAR to the 480 milliseconds, and 330 milliseconds of the alert period will be there, so that the P wave is fallen in the PVAR period, so that it will not allow to initiate any kind of PMT. So this is where in ECG also we can see 480 milliseconds of refractory period initiated after the PVC, and 330 milliseconds of alert period, so that it was not initiated anything after the PVC. Yeah, this is also one more method of the prevention for the PMT in the Senjure. So earlier it was directly it was increase in the 480 milliseconds of the refractory period. One more method, APACE after PVC. So what happens here in last slides, if you see that 480 milliseconds of refractory period and 330 milliseconds of alert period is there. It will be very long to compensate of the pause. To compensate of that pause, so in Senjure they are introduced the new method of after PVC. It will just increase the 330 milliseconds of the refractory. Then if after 330 milliseconds, then it will pace in the atrium, to make sure not to have the big compensatory pass. This is another method of Senjure to prevent the PMT on the PVC. Yeah, that was the prevention of the PMT. This is the treatment for the PMT. So basically, even after the prevention of the PMT, so there are some situation it can reinitiate the PMTs. So after initiating the PMT, so how to treat that PMT? Pacemaker is having the one more option to treat the PMT. So what this is 10 beats. It looks for, if it is a certain rate of the PMT, we can set up that what is the PMT rate. Usually nominal value will be at the MTR rate. So 10 beats, consecutive 10 beats more than the PMT rate. So it will start increasing the refractory period. You will see here. Yeah, usually PMT detection rate is here 110. So after 10 beats, consecutive 10 beats crossing this 110 rate, so it will initiate the PMT treatment. Yeah, PMT treatment of, again, PURP extension of 480 milliseconds followed by the 350 milliseconds of alert period, so that it will fall that any kind of retrograde conduction inside the refractory period, so that it will break the PMT. So we can see here same thing. So here after one PVC, no, yeah, here it was the device has detected as a PMT. So it has looked back the 10 intervals of the RR intervals, it has crossed the PMT rates. So then on 10th bit, it has increased the P VAR. So this particular P wave is fallen into the refractive period. Then it was broken the PMT. So, but still it looks like a PMT was not broken. So it is continuing at the similar rate of the PMT rate, because yes, if it is continuing the after the PMT prevention termination feature also, then again it will repeat the same termination feature after 256 cycles. Yeah, we can see here it was the continuing even after the termination feature was applied of the 480 milliseconds of the refractive period, but it was continuing. So that is where after 256 cycles, it will continue in the extent of the PVAR. And one more method of this PMT treatment. So auto detection, it was in last detection method, it was the 10 cycles, consecutive cycles crossing the PMT rate, it was initiated. But here more approximate method as initiated by the Censure. This was the auto detection of the PMT. So what it does is once it is crossing the PMT rate of the 110, whatever you have set up in the programmer. So once if it is crossing the PMT rate, it will look back the last 8 intervals of the VA cycles, and average of those 8 cycles of VA intervals, then compare with the each VA interval. The each VA interval differences is the less than 16 milliseconds. So device decides that the rhythm is stable. So it feels that retrograde PY is stable. So it could be the PMT. So then it detects the PMT based on this criteria. 8 VA cycles it takes, average of that 8 VA cycles compares with the each VA cycle. The difference is less than 16 milliseconds. It decides that it is very stable, and retrograde, because of retrograde conduction, it has initiated. So it decided as the PMT. Then once after detection of the PMT, on 9th cycle, it will increase or decrease the AV delay based on the AV interval what we have kept at. So once after shortening or increasing the AV delay, on 10th cycle, again one more time it will reconfirmation of the VA interval. If it is still the VA interval less than 16 milliseconds, then on 10th cycle it will one beat V pace will inhibit, so that one after Ason's V pace, one inhibition in the ventricular pacing, definitely it will break the cycle of the PMT. That is what here on 10th cycle it will inhibit the one ventricular pacing, so that it will definitely break the PMT. So after PMT break, after 10th cycle of the inhibition, then after 330 milliseconds of the alert period, it will pace in the atrial to compensate pause. So here we can see. So it was checked about the 8 VA cycles, average of the 8 VA cycles compared with the each VA cycle, it was less than, the difference is the less than 16 milliseconds. Then it decided on 9th bit, it has decreased the AV delay. On 10th bit, A sense was there, but V pace was inhibited. So it was broken. Then it is pacing in the after 330 milliseconds. Then it started pacing in the atrial to compensate to reinitiate the regular pacing. So this is what auto detection algorithm to terminate the PMT happens. Here we can see. So one bit of inhibition was happened in the ventricular. Then after it started regularly in the atrial pacing. You can see it was, I think, looks like it was the the PMT initiation. Yeah, here we can see again very clearly the initiation of the PMT was very rapidly happened, and one bit of ventricular pacing was inhibited here. So we can see here very clearly, and then started pacing in the atrial. Rate has come down to the base rate of the pacemaker. So we can see very clearly the rate initiation for the PMT, then it has broken with the PMT termination feature. Yeah, basically these are the two treatments by the pacemaker: prevention of the PMT and treatment of the PMT. In prevention of the PMT, it extends the PVAR on every PVC, and PMT treatment, it detects, look back the VA intervals and compares and start the treatment of the PMT. So earlier, as we discussed, these are the all causes for the initiation of the PMT. PVC are the most common causes for the PMT initiation. Yeah, this is what PMT, sir.
So anything which is sensing issues in the dream,
Yes, sir.
it can cause.
Yes, sir.
Or
Like
sensing non-capture.
Yes, sir. Like oversensing and undersensing of the atrial and loss of atrial capture. So all these are also causes for the pacemaker-mediated tachycardia.
How frequently it will happen in complete heart block?
In complete heart block, sir. Complete heart block very rarely, I believe, sir. But there are chances still because, sir.
How much chances?
Chances maybe exact percentage I do not know, sir. But there are chances because most of the times even we see in the complete heart blocks also. Because if it is out of AV node is the out of refractory, so then it can go back to the atrial. So that time that is the chances it can happen in the complete heart blocks also.
So as such, we think that AV block is there, so patient will not develop.
Yes, sir.
There is no VA block.
Yes.
Patients who are having AV block,
Exactly.
around 40%.
Oh, 40%.
36 to 40% chances
Oh,
of VA conduction.
VA conduction can happen. Yes.
And in that chances will be more because the VA is, the conduction is slow.
Yeah.
So in that it will be falling out of the
Refractory.
If the valve is not properly
Yes.
addressed, it may happen. But if patient is having complete heart block and later on pacemaker is usually what we implant pacemaker in ESVD patients. After ablation, due to the pathway, mid-septal pathway is a very common pathway when we ablate. And we think that probably we have ablated and the patient has developed complete heart block.
Yes.
The chances of developing the PMT is a bit high because we have damaged the AV conduction, not the VA conduction.
Yes.
After putting the pacemaker, patient will be having again palpitation. So in that scenario, we have to go and ablate the VA pathway so that, or we can say VA conduction, so that the patient should not have. So this scenario we will be getting commonly.
Most commonly. Okay.
Yeah. So even in a single channel pacemaker patient, we will be complaining palpitation. This scenario is basically meant for the dual chamber.
Yeah.
So pacemaker-mediated tachycardia only and only for the
dual chamber we are talking about.
But when we are doing the ablation and suddenly the patient develops complete heart block, like a mid-septal pathway or septal pathway, and we are putting a temporary pacemaker, later on permanent pacemaker, and he's again coupling the palpitation.
Okay.
Is it possible that it can be due to the pacemaker?
Maybe, but I don't know, sir, because if it is VA conduction can happen, but palpitation, PMT, it cannot initiate, definitely. But because of pacemaker, I don't think so, sir. Maybe this can go back to the, as you said, that VA conduction can happen. If it is a higher rate we are keeping, maybe that could be the one scenario. Maybe if you are keeping 100 or more than 100, if it is going back to the VA conduction, maybe that is the one scenario you can feel.
Usually, PMT is not possible because unless we are putting a VDD pacemaker.
PMT will not happen, sir. But as you mentioned about the palpitation, this if we are keeping the higher rate, is there any possibility? 100 or something like that. That's possible. Okay.
So let me summarize in those questions how much they are going to understand.
Yes, sir.
Okay. Yeah. Thank you. Thank you, Kishan. So question goes to Uzman. What do you understand about this PMT? He's saying pacemaker-mediated tachycardia. What exactly he was saying?
Tachycardia is caused due to the pacemaker machine and how to prevent it and treatment.
Tachycardia caused by pacemaker. Are you sure that it is like that? So what are the two components he was discussing? One is prevention, second treatment, that is okay. But what are the two components essential to develop the PMT? Premature ventricular contraction. Okay. Anything more? Okay, that are the causes. But what are the two components? Because this is second class. I think last time this has been discussed with the other company also, PMT, and since again the protocol is on the different company. So I think last time Metronics, no, Boston has given the presentation for that. So the important thing is there are two components are essential. One is pacemaker. Without pacemaker, it will not have. That's why we are saying pacemaker mediated, not caused by, mediated. And the second, there should be a two-way traffic. Two-way traffic is means one-way traffic is AV, atrial to ventricle conduction should be there, and there should be simultaneously VA conduction should be there. VA can be through the node or through the extra node. Means the person should have a AV nodal conduction and at the same time AV can go backside, which is commonly seen in most of the patients. But if the patient develops complete heart block and if it still develops this one, it is possible that some pathway is there. So when we have put the pacemaker, VPC has come and it is started conducting. So it is not the AV conduction, it is the pathway which is conducting. Pathway means extranodal atrioventricular connection is there. So that also will lead to the this one. So pacemaker and two-way traffic between atria and ventricle are essential component to develop pacemaker-mediated tachycardia. And what triggers this? So what we are saying, it is APC, VPC, non-capture of a atrial or loss of sensing of atrial lead. So all those things are the causes of this one. Means they are trigger, but components are pacemaker and two-way traffic between the atria and ventricle. And how to prevent all those things he has told regarding. I will not go in detail. So in summary, two component means if a patient is coming with a complaint of palpitation in a pacemaker, there are two important things, whether it is a pacemaker mediated or not. You are not having anything and he is still ongoing palpitation is doing. So what next you are going to do? No. He is having pacemaker. I am coming to you. I am having palpitation. You know that I am having device you have sent. You have seen the pulse. My pulse is going around 170. So what is the next reflex you want to do? इंट्रोगेटर नहीं है आपके पास में. हाँ, good morning. Next, what you are going to do? Yes, this answer I wanted to. You were saying also, you will not get everywhere. First of all, you do the ECG. If ECG you are getting a tachycardia in which the spikes are coming and the rate is around 170, 180, whatever is been the we call as a higher tracking rate. What you are saying, device when it has been implanted, after that there is a sorry, let me. So tracking rate will be coming on that one. So tracking rate will be coming. So the tracking rate is MTR, no, maximum tracking rate. So that depends on the how much AV conduction we are making it. So it has been device at 2:1 AV block will be coming. So if the device is tracking at higher rate and only we are getting the V pace, not the A pace, most of the time V pace will not be visible when it is the heart rate is very fast. So if you are getting, and how to differentiate, just this is the iPhone. So usually if you are going to put the iPhone, it is having a very big magnet. Sometimes it can interrupt it also. Not expected, but sometimes. Otherwise, you have to take a round uh, magnet, and I think 40 gauss with that.
10 gas. 10 gas is minimum.
10 gauss, GAUSS. Put on the device, it will stop, and we'll see the pulse is normalized. When you are taking out, again it is coming. So it is when you are putting, all of a sudden the sensing is off, and it is all the story. Means PMT is a story of sensing issue. Something has been sensed in the wrong way, and device has been interpreting that you have to pace at that rate. So atrium has been sensing in a wrong way that okay, you have to think, and it started tracking. It should not track, but it started tracking it. So sensing and tracking is happening, and which we break by putting a pacemaker. Thank you, Kishan, for everything. We will be seeing next time again. The topic will be the crosstalk. So crosstalk is also one of the important event, or you can say abnormality or malfunction of the pacemaker, where the two wires will start interacting in a wrong way. We are having dual chamber pacemaker, atrial and ventricle. Ventricle has to pace and ventricle time, atrial has to pace in the atrial time, but they started, मैंने तुमको काम दिया, तुमने ना बोला उसने काम करेगा, and nobody has worked, and finally the patient has stand still. So two devices, two wires has been in, ventricle has to be paced, atrial has to be paced, but it has sense कि ventricle को pace नहीं करना, and it started stand still. So the patient is pacemaker dependent, means the pacing is the important function for patient, means we have implanted for like a complete heart block patient, and ventricle is thinking that I have not to pace because I have sensed something, means heart is having its own activity and it has become standstill. That is called crosstalk, and there is a ways and mechanism to detect. Sometimes patient like ICD patient may be having palpitation and giddiness. So when you are doing the device, you will say, oh, the patient is having VT. But when the VT has terminated, after that, the patient is having giddiness because there is some other issues has happened. So in the next class, we will be discussing all those things. Thank you.